So there are some structural differences, like we talked about, between the different ribs, or between the different vertebrae. For example, the cervical vertebrae are all going to have these things called transverse foramen, because nerves are going through there. The first two have a name, right? So atlas is the first one, that's the one that's directly cradling your occipital condyles. And then the atlas, or sorry, the axis has that dens, little tooth-like projection that allows your head to pivot and rotate that way. Your thoracic vertebrae are going to have facets for your ribs. So all 12 of your ribs are attached to the thoracic vertebrae. And then the lumbar vertebrae are going to have large, thick bodies. We'll go over, actually, I'll just wait till lab, we'll talk about it. Identifying is pretty easy to do so. Okay? In physical therapy, right, so one of the things we deal with in physical therapy is people who have abnormal spinal curvatures. Okay? There are a couple of different types of abnormal spinal curvatures. Somebody in here was thinking about, yeah, she's not here. Should go for PT. Anybody else thinking about going for like PT or anything like that? So, okay. So we've got a couple of different types of abnormal curvatures of the spine. So the first one we can have is called kyphosis. So kyphosis is abnormal curvature of the upper thoracic spine. What would cause kyphosis? So kyphosis is caused by a couple of different things. So number one, like a really bad kyphotic curve is typically like what you see here. Really bad kyphotic curve, that's usually genetic in nature. But what would start to cause moderate kyphosis? Poor posture. What are some of the things that cause poor posture? So weak muscles, right? Or excessive muscular imbalances, right? So we've got kyphosis, right? We have lordosis. So lordosis would be an excessive curvature of the lumbar spine. Same kind of thing there, right? So what type of musculature would have to be out of whack to cause excessive kyphotic curvature? Huh? So I'm sorry, for kyphotic, this kind of curvature. What would have to be out of whack to have excessive kyphotic curvature? So, right, so typically musculature on the anterior portion of the shoulder girdle being excessively tight, musculature on the posterior portion of the shoulder girdle being excessively weak, right? So what might a physical therapist do? So we might prescribe a program to stretch and relax the muscles through here, strengthen the muscles through here to help pull everything back into muscular balance. What would happen with lordosis? So you got that kind of thing going on. So you might have weak musculature here, tight musculature here, right? Weak musculature here and here. So we would typically want to strengthen this, stretch these muscles, strengthen maybe some of these muscles back here. Okay? And then we have scoliosis. So scoliosis is a lateral curvature of the spine, either one way or the other. What would be causing, for example, in this young man, what would be causing scoliosis in this young man? So it's his spine is curving to the right. Could be, yeah. So for whatever reason, we're not sure exactly, right? Or like this young man that was here, right? So for some reason, there's an unevenness in the strength of the musculature on the right side versus the left side of the scapula. So we might stretch the musculature on that side of the scapula and strengthen the musculature on that side of the scapula. So severe, curvatures of kyphotic, lordotic, or scoliotic, right, where there's surgery is the only way to fix that. But mild ones we can fix with muscular, corrective exercise, which is a big part of what we're doing in physical therapy. So a large part of what we're doing in physical therapy is fixing muscular imbalances that are causing dysfunction in spinal processes, joints, kind of things like that. Okay. We're seeing an increase in things like scoliosis and lordosis in our society. Why are we seeing an increase in that? Not severe amounts of scoliosis or kyphosis or lordosis, but like low levels of kyphosis and lordosis. Yeah, right. So we spend a lot of time like this, right? We typically tend to see this a lot in elderly people, right? You see an old person, right, walking, right, they're scooped over. So because they don't have enough strength in order to keep their spine going forward. Sure, doing that, yeah, driving, kind of things like that, right? So a lot of this could be fixed by, sometimes. Do you have a question?
Is scoliosis related to like obesity or anything like that? Like for those curvatures?
Related as in?
Like if they're playing gaming and like eating and like the poor posture.
Not scoliosis, but lordosis and kyphosis, especially kyphosis or lordosis. So, for example, when you're pregnant, right, it's typical, like we would expect to see some lordosis, right? So as the center of mass starts to move down and forward, right, the low back has to change in order to accommodate that. It's very common for women in the third trimester of pregnancy to experience quite a bit of back pain due to that. But yeah, so for kyphosis and lordosis, definitely, yeah, obesity and inactivity could contribute, especially lordosis, it could contribute to it. You see like those dudes with like the big old beer bellies, yeah, they're probably going to be lordotic. Similar kind of shift in center of gravity, like an 8 or 9 month pregnant person. Pregnant woman, so yeah, you would start to see some. Each of your vertebrae has limited amounts of movement, but because we got lots of them, we can have a relatively good range of motion. Okay? So the movements that you can have with your spine are, so we can have flexion, extension, and then we would call this lateral movement, right? We wouldn't call it abduction or adduction. Why not? So abduction is away from the midline, adduction is toward the midline. Why would we not call this abduction or adduction?
Because it is the midline?
It is the midline, right? So it's kind of hard to move away from the midline when it's the midline movement. So flexion, extension, lateral movement. In between each vertebrae, we have intervertebral discs. Intervertebral discs are made out of what's called dense fibrocartilage. And so there's lots of dense fibrocartilage, and there's kind of like this gel kind of in the center. If you want to name the disc, you just simply name the two vertebra. It's in between. So for example, a lot of people will end up with, due to poor biomechanics or other kinds of things, where the material in between will get pinched and it will start to bulge or tear. So we have a bulged or a tearing disc. So a very common one would be like right here. So this is the 5th lumbar vertebrae. This would be your sacrum. So you might say that you have a herniation of L5, S1. Another common one is L4, L5, and then L3, L4. And so we refer to the two vertebrae that the disc is in between. So if you have a herniation or some kind of damage to the disc, you would say it's L4, L5, L3, L4 because it's between the 3rd and the 4th vertebrae. This is very, very common in the United States. It can be caused by a variety of different things. So again, poor biomechanics, not lifting properly, weakness in the muscles. Some of it's also, like many things, genetic in nature as well too. Any questions on that? So you got the sacrum. The sacrum is several vertebrae that are fused together, that fuse together in utero. So at one point they're independent, but they start to fuse in utero. And then we have the coccyx, which are 4 or 5 vertebrae that are fused together. So again, like all mammals, right? All mammals have tails, right? Ours is just internal, it's not external, it's kind of tucked up under. We'll talk a little bit more about it in lab today, but I'll talk to you guys about why females are far more likely to have a fracture of their coccyx than males are. Right? So it has to do with some of the anatomical and structural differences in the pelvis between males and females. So we're gonna take a look at the vertebrae today, and we're gonna take a look at those. So today is gonna be the rest of the axioskeleton. Okay. Talked about this a little bit on Tuesday, but we got the thoracic cage. So the thoracic cage helps protect and enclose a lot of your organs, your heart, lungs, and some of the other organs. So the top 7 are called the true ribs because they're directly attached to the sternum or manubrium. And then we have the 5 false ribs. The bottom 2, which are called floating ribs because they aren't attached by anything. Talked about those are what spare ribs are, right? So you eat spare ribs at a barbecue. There are rumors that several actors and actresses have had those ribs intentionally removed to bring the waist in. So Cher was rumored to have done it. A couple other performers were rumored to have done it back in the day. So here's an interesting thing. So during Victorian times, the premier beauty standards for women were to have a ridiculously tiny waist. This isn't a doctor picture. This is a woman who actually had her waist narrowed down to that. Right? So they would wear, starting at puberty, right? Ladies would wear these corsets, which would be cinched tighter and tighter and tighter in order to narrow down their waist, right? So the ideal was to have a 18-inch or narrower waistline, right? Which is just insanely impractical to have, right? So, needless to say, it would compress the organs and do other stuff like that to the, right? So over time, right, the ribs would get slowly compressed in and in, especially those floating ribs at the bottom, right? Anybody ever seen one of these? So these were fashionable to have in almost any Victorian home of a fashionable lady. Who's seen a movie set during Victorian times? All right, so see a lady, right? She's got the corset, she's got all the clothing on, all of that, right? And, right, she's constantly like fanning herself, and right, something even slightly upsetting or happens, and what will they do? Right? Is that a sexist portrayal of Victorian women? Painting couches, yeah. Look at this, right? How hard? Try breathing wearing that thing, right? Of course it would be, right? So imagine, right, it's Victorian times, right? You're wearing probably 20, 30 pounds of clothes here, right? It's a warm day, right? Walking around, pretty damn hard to catch your breath, right? So it's pretty common for these ladies to faint.
So when is Victorian? When was that?
Victorian era, so generally during the reign of Queen Victoria, so generally the late 1800s, so about 1900, 1910 is considered to be the Victorian era. I mean, it was permanently, yeah, I mean, it would be less narrow, but a lot of these women really started to struggle with being able to function without wearing the corsets. Right? So they would have to wear the corsets because, the corset kind of stabilized everything, and so it turned off a lot of the postural muscles in the spine, right? So they couldn't function without them. So it was one of the crazy beauty standards, kind of like the feet binding that the Chinese did and things like that. So, I mean, think about that, ladies. Think about it like that, having your waist cinched down to literally 18 inches. That's just. They would not wear them when they were pregnant. Well, a lot of them, especially, they would, like, after they had kids, they would. Back then, if you were pregnant, it was expected that you would be not seen. Yeah, so you would try to, like, hide the fact that you were pregnant. We all knew where babies came from, but we wanted to just, like, pretend like that. It was a weird time, people, so like those bottom ribs would get compressed in, right, and everything would get compressed in over time, and that would cause serious deformations. It can get more difficult to have children, all sorts of different types of dysfunction. functions. Of course, it's got some serious health issues. We also have the pectoral girdle. So the pectoral girdle, it's an incomplete ring of the upper limb. So you've got the scapula, the clavicle, and the humerus. So kind of, and then the couple of ribs here. So this kind of whole thing here is called the shoulder girdle. There are lots and lots of muscles and tendons that are in this area. We'll talk about more when we get into joints here pretty quick. So because there's so much stuff going on here and they're all kind of connected and interwoven together, it's very easy for somebody to have some type of musculoskeletal issue with their shoulder girdles. Anybody here had a shoulder problem at some point? Right? So it's very common, especially if you play sports, especially what we call overhead sports. Can you guys give me some examples of an overhead sport?
Baseball.
Right. Right, so baseball, softball, tennis, swimming, volleyball, football, lacrosse, water polo. I don't know how they get them horses to swim. So it's very, very easy for people to have issues of the shoulder girdle, right? And there's a lot of orthopedic surgeons who basically all they specialize in is issues involving the shoulder girdle. All right, let's take a look at the upper limb. So the bone, so there is your arm and your forearm, right? So this is your arm and this is your forearm. So the bone of the arm is the humerus. You've got the head of the humerus, and then you've got these two large bumps. Remember when we talked about this on Tuesday, any type of like extension or protrusion or large bump coming off of a bone is usually an attachment point for muscles. So this is an attachment point for several muscles on the body. You have the greater and lesser tubercle. The greater is more posterior and lateral, and the lesser is more interior or anterior and medial. So in between the two is what's called the intertubercular groove or sulcus. Sulcus is like a groove. It's also sometimes called the bicipital groove because the long head of the biceps travels up there. So a lot of people who have experienced tendinopathy or tendinitis of the biceps will often experience discomfort and pain in the front of the shoulder. So that's often indicative of somebody that's done something to their bicep. About halfway down is a little bump called the deltoid tuberosity. So the deltoid tuberosity is the attachment point for the deltoid muscle. So the deltoid muscle is a triangle-shaped muscle, attaches kind of right about here is where it attaches. And then you got the condyles and the epicondyles. So the medial lateral epicondyle, again, attachment points for large muscles, mostly of the forearm. And then you've got two fossas here. So you got the coronoid fossa, which is anterior, and then you got the olecranon fossa, which is posterior. The coronoid fossa articulates with what's called the coronoid process of the ulna. This is what limits elbow flexion. And then the olecranon fossa articulates with the olecranon process, and that's what limits elbow extension. Right? So elbow can typically only extend to about 180 degrees, and it can only flex to, even if you had no musculature, right, on a skeleton, it would still only go to about 20 degrees. Well, I can show you how anybody does that. Hold on. So it would only go to about 20 degrees as a result of that. Okay. Then we got the forearm. So we've got the ulna, or the radius and the ulna. Ulna kind of looks like a wrench. So you've got those two processes on the ulna. You got the olecranon process, which again articulates on the posterior aspect of the humerus. And then you got the coronoid process, which articulates on the anterior portion. So the coronoid process is what limits flexion, and the olecranon process is what limits extension. Anybody here a fan of like MMA, grappling, stuff like that? So, right, so if you try to put somebody in an arm bar, right, you're trying to extend the elbow beyond 180 degrees going into hyperextension. Arm isn't meant to go beyond into hyperextension. So if you try to force it into extension, it's very painful. It usually makes people go, okay, I'm done. Okay. And then you also have this thing called the radial notch. The radial notch allows the radius to pivot. so that you can do what we call pronation and supination. Okay, so this is supination, right? So you want to hold a bowl of soup, that's supination, and then hands down is pronation. So this is because your radius can pivot. So you have the head of the radius, and then on the, this is all on the proximal end. Right here, this is called the radial tuberosity. The radial tuberosity is the attachment point for the insertion of the biceps brachii. So your brachii, your biceps brachii inserts here into your radius. So when you contract or shorten your biceps brachii, it flexes the elbow joint, meaning it decreases the angle of the shoulder joint. It also supinates the shoulder, also supinates the elbow joint. And it's a weak flexor of the shoulder as well. Okay. On the distal end here, we've got the styloid processes of the radius and the ulna. These articulate with bones in the hand, and why one of the most common breaks people have is wrist fractures, which we'll get to here in a second. Okay. So we got our wrist bones. So our wrist bones are what we would call short bones. Okay. We've got 2 rows of bones. There's 3 in the proximal row. So the 3 in the proximal row are the capitate, scaphoid, and pisiform. And then we've got the triquetrium, trapezium, and trapezoid. Right there, okay? So right here, so you got the radius and ulna, they will, with the hamate and the lunate bone. So the hamate bone, because it looks like a piece of ham, and then the lunate bone, because it looks like a partial moon. That's what the hamate and lunate. So 2 of the most commonly broken bones on the body are the hamate and the lunate, and then also the pisiform bone. Because, right, you fall backwards, right? Hand goes into the ground, right? And then the 2 radius, the radius and the ulna, slam into the hamate and the lunate, and they fracture. Right? So it's a very, very common injury that people have. Or they will break the radius and ulna, or all of the above, right?
Mm-hmm.
Anybody know somebody that did that as a kid, like fell off a swing or something else, went back to brace themselves and broke their arm, right? Broke the wrist, so it's a very, very common injury. Okay? All you really need to know for this class is there's 3 in the first row, 4 in the second row. Okay, so trapezium, trapezoid, triquetrium, and pisiform in the distal, hamate, lunate, and pisiform in the first row. Okay, then we got the hand. Okay, so we've got the bones of the hand. Those would be the metacarpals. Right. So from anatomical position, which again is palms out. Okay, so we've got our first, second, third, fourth, and fifth metacarpal. Okay, so 1 through 5. One of the also most commonly broken bones in the body is the 5th metacarpal. This is often called a boxer's fracture. Right, so punch something you don't know how to punch properly, or if you do sometimes, if you hit on the hard surface, right, it'll break this bone right here. So it's a very, very common injury that we have. And then we have the phalanges. Okay, so phalanges comes from the Greek word phalanx. Can anybody tell me what a phalanx is? Right here, so the movie 300. They kicked all the Persians off the cliff. Right, so it's a battle formation that was popular in ancient Greece and ancient Rome. So it reminded them of, right, a battle formation. So on your thumb, okay, you've got your first proximal and distal phalange. Then you got your second, 3rd, 4th, and 5th proximal, 2nd, 3rd, 4th, and 5th medial, and 2nd, 3rd, 4th, and 5th distal phalange. So on the pollex or thumb, you only have a proximal and a distal, while as in your other fingers, you've got a proximal, medial, and distal phalange. Okay? So 1, 2, 3, 4, 5. Okay, we always, by default, this is anatomical position. All this make sense?
So what's a phalange?
So phalange is your fingers.
All 3 of them?
Yeah. Yeah.
Or 4?
Yeah. Well, so there are, how many phalanges do you have in your fingers? You got 1, 2, 3, okay. So 12, 13, 14. So you got 14 phalanges per hand. Right, so you got 28 phalanges in your hands. And then you got 28 phalanges in your toes. We call them phalanges in your toes. So significant chunk of the bones in your body are hands and feet and wrists and ankles.
fact, your feet are so important, and there's so much stuff that can go wrong. There's an entire field of medicine purely devoted to your feet. What would that be?
A podiatrist.
Podiatry, right? So you can be a podiatrist and just work on your feet. That's not important to your feet. So. By the way, if you're looking for a good career, become a podiatrist. It'll be a pretty good one.
That's disgusting.
What?
You look at people's feet all day, those are weirdos.
Better being a proctologist.
That's true.
What's it?
What's that?
Huh?
I don't even know.
What's a
if I
proctologist,
want-
guys? Proctologists are doctors that specialize in colorectal issues.
Oh.
Yeah, that's.
Wait, you can't call
Huh?
that. They pay well for that.
They do. Well, I mean, they all pay pretty well. But yeah, podiatry pays pretty well. But yeah, you are going to be spending a lot of time doing bunions and
Or-
growing toenails and
Disgusting.
stuff like that. But
Like, no one goes to the doctor with a perfect foot.
Some just go for nail care.
you'd be amazed what you're willing to tolerate for $250,000 a year.
That's true.
Mm-hmm.
I'll tolerate it.
So it's about what podiatrists make. So.
Yes.
Okay, let's talk about the pelvis here, and then we'll pull out the model, okay? So you have two pelvises. You have a left and a right, what we call os coxae, okay? So your os coxae is three bones which fuse together, well, you're in utero, okay? Here, I'll show you guys here on the model.
Os coxae.
So the superior bone is the ilium, right? So some of you can actually palpate this. You can actually palpate your iliac crest. Okay. We then have the inferior and anterior bone, which is the pubis, right? So that's right here, your pubic bone. And then you have the inferior and posterior ischial bone. So right now you guys are sitting on your ischial, here we call this your ischial tuberosity right there, okay? Where the three bones fuse together, we have a socket, right? So this is called the acetabulum. It's very similar to what's in the scapula. So on the scapula, you have what's called the glenoid cavity. We've got two ball and socket joints. So we've got the shoulder joint, and then we've got the, so that's called the GH joint, the glenohumeral joint, and this is called the FA joint, femoral acetabular joint. Right? So both of these joints are pretty mobile. We'll talk about joints here a little bit more in a second. Okay, so some of the anatomical structures, right? So this is called the anterior superior iliac spine. Okay, so spine is a projection. This is the anterior inferior iliac spine. Anterior posterior and anterior inferior iliac spine. This is called the pubic symphysis, right? And this is called the inferior and superior and inferior ramus. So ramus is like a straight line of the pubis, right there. And then these are called the ischial tuberosity. So again, any of these bumps or protrusions are attachment points for large muscles. So for example, your gluteal muscles, right? So the muscles on the back of the hip are here. Some of your hip muscles, the front hip muscles are here. So for example, the muscles that are involved in hip flexion, right? They're going to be attaching kind of here. All right, and then we've got the sacrum and then the coccyx. Okay, so ladies, why are you more prone to having a coccygeal fracture than men are? Okay. I've got two pelvises here. One of these pelvises is a male pelvis, and one of these pelvises is a female pelvis. I'll come around so you guys can take a good look at them.
Yeah.
Yeah, I'll come around and show you this way, and then I'll show you the other way.
Looks like our coxal is more straight.
So this here is called the pubic arch. Okay? So this pubic arch is more U-shaped. This pubic arch is more V-shaped. So I'm going to turn it this way. Which of these two would be easier to push a baby through?
The bigger one.
This one on this side, okay? So look at it this way, okay? Where's the coccygeal on the male pelvis? Tucked up more. Where's the coccygeal and sacrum on the female pelvis? It's pushed back more, right? So you slip and fall, right? Land on your butt, right? mass, what are you gonna land on? You might land on your, right, so it's very common, especially younger girls, right, so a lot of young girls oftentimes will end up with a fractured tailbone or fractured coccyx. This also leads to some of the biomechanical differences between men and women. So women, because of their wider pelvis, they have a higher what we call Q angle. So the angle at which the femur attaches to the pelvis, right? So in men, it's more linear, whereas women, it's more at an angle. This makes women less biomechanically efficient. So the force that's generated by the hips, less of it gets transferred to the ground in women versus men. Who's the fastest man to ever live in the 100 meters? Usain Bolt. So Usain Bolt at the Olympics ran it in like 9:55, something like that. Anybody know who the fastest woman ever was? So at the 1988 Olympics, an American sprinter named Florence Griffith Joyner, commonly known as FloJo, set the world and Olympic record at 10:66. No one's really gotten close ever since then. The fastest woman that ever lived was about a second slower than the fastest man that ever lived to that. And this is true at every distance. Now here's where it gets weird though, okay? So 100 meters, 200 meters, 400 meters, 800 meters, 1600 meters, 3,000 meters steeplechase, 5,000 meters, 10,000 meters, half marathon, marathon. Men are by far faster, right? So like the world record for the marathon for men is like 2 hours, 2 minutes. For women, it's like 2 hours, like 20 minutes. Like that's a significant difference. But here's where it gets weird. Women are better at ultra marathons. So like the best ever 100 mile run is by a woman. And the longer the distance, the better women do. We can't figure out why it is. But we think it has to do with women having higher pain tolerance. Yeah, so but that's why women are not as fast as men are. So it's largely due to that, plus muscular differences and a few other things. Okay. So that's those are our that's our pelvis. Then we got the leg, the thigh, and the leg. So anatomically speaking, this is your thigh, that's your leg. Okay, so we're talking about thigh injury, that would be the the femur, and then a leg injury would be the tibia and fibula. By the way, over here is what we got. We got ourselves a tibia over here. Okay. So the femur is the longest, largest, and strongest bone in the body. We have yet to design a synthetic femur that is as strong and as light as the natural femur. Right? So again, Mother Nature, she's a heck of an engineer. She's much better than we can. We can design a femur out of synthetic materials that is stronger. We can design one that's lighter, but not the same strength to mass ratio as the one that you're born with. You've got the head of the femur. Okay? On the head of the femur, there's this little thing called the fovea capitis, to which there is this ligament attached called the ligamentum teres. That's what helps keep your femur inside of the socket. On your glenoid cavity and also on your acetabulum, it's covered in a large cartilaginous kind of cup that's called a labrum. Right? So it's very, very common for athletes to have some type of a labral tear, either of the shoulder or the hip joint. Back in the 80s and 90s, there was an athlete. He was a Heisman Trophy winner at Auburn University. He was also an All-American in baseball. He got drafted by the then Oakland Raiders as well as the Kansas City Royals and played professionally for both the NFL and the Major League Baseball at the same time. His name was Bo Jackson. Here's heard of Bo Jackson, right? So Bo Jackson was a pretty good player at both sports. Not great, but pretty good at both. And then he got tackled and dislocated his hip in the process of getting tackled and ended up tearing the labrum really bad, and then it got infected, and then there was necrosis, and he ended up having to have a hip replacement, and it pretty much ended his career. At the same time that Bo Jackson was playing, there was two other athletes who were playing both professional football and professional baseball. One was a guy named Brian Jordan. He was a safety for the Atlanta Falcons, and then he also played baseball for the Atlanta Braves, and then later the St. Louis Cardinals. And then there was another guy. He was a safety and defensive back. He played for the Atlanta Falcons as well as the New York Yankees and a couple of other teams. He quit baseball because he wasn't very good at it. Went on to become one of the greatest football players of his generation, and now he is the head coach at the University of Colorado. His name is Deion Sanders, prime time. So all three of them played professional football and baseball at the same time, but they all kind of like went in their separate directions because Bo tore the labrum, right, and ended up getting affected, and then he ended up having to quit baseball, or quit sports. So Bo Jackson's one of the great what ifs. Like if he never got hurt, what would happen with his career? He might have been a Hall of Famer in both sports. We'll never find out. Okay. So we got the head, right, and then we got the greater and lesser trochanter. The greater is superior and more posterior. And then you got the lesser trochanter. Again, these are attachment points for large muscles. There's also this little thing called a gluteal tuberosity. We'll take a look at that in lab in greater detail next week. Attachment point, insertion point for the gluteus maximus. And then on the back of the femur, on a real femur, it's very rough textured. It's what we call the linea aspera. It literally means rough line. It's an attachment point for your hamstring muscles. Your hamstring muscles. Okay? And then we got the condyles, which again are also attachment points for muscles. Epicondyles and then the lateral condyles. Here on the front, we've got the patellar surface, which is where your kneecap is. What is the function of your kneecap, guys? That's a good guess, and partially true. That's part of it. So protection. What else?
Absorption.
Absorption of.
Like force when.
Yeah, well, yeah. So protection. Yeah. So its main function. So it does help with protection, but its main function is to increase leverage, mechanical leverage. Okay. So you've got the femur, you got the tibia, okay, and then you got the kneecap over it, and then the muscles of the femur go over that. So it increases mechanical leverage, right? So let's say like you're trying to root something out of the ground, right? You might put a block down, what we call a snatch block, and then you use your crowbar, right? What does that lever do, or that box that you put down do? Or the block you put down? It helps increase the mechanical advantage, gives you more leverage. So that's what that plus protecting the underlying tissues and absorbing some of the shock is what the kneecap does. Okay?
Is that why when you were, like, when I did PT for my knee, she basically was like, you should try to make your thigh muscles and like below it because it will help keep it in place?
Yep, that's exactly what I did. Okay. So that's, then we got the tibia and fibula, which is the leg. So the tibia is the major weight-bearing bone. The fibula is primarily involved in articulation. We've got the tibial tuberosity, so you guys can palpate that. So palpate your kneecap, okay, and then go just below. There's a little knob there, right? That is your tibial tuberosity. That's the attachment point for the big four muscles on the front of your thigh called your quadricep muscles, right? So there's four of them. So we call them quadriceps, okay? And then we've got the fibula, which has got the head of the fibula, and then the lateral malleolus. You guys can palpate the lateral malleolus. That's your ankle bone. So the outside of your ankle there, that's your lateral malleolus of your fibula, okay? And then the medial malleolus, they come together, and they kind of sandwich between a bone here in your foot called the talus to make what's called the talocrucial joint. Right? That's your ankle joint, so that allows your foot to do this, okay? Super unstable though, so excessive lateral or medial movement can cause tearing of ligaments, leading to a sprained ankle. Then we got the foot. So let me grab a foot here.
Did you know that a sprain hurts worse than a fracture?
You said a sprain's worse than a fracture.
You feel it worse.
I've never fractured anything.
Like there's always like, oh, it kind of
Anybody here had an ankle strain?
But just fracture for
Anybody here a broken ankle? I did 4 times.
Oh wow.
Playing sports.
My ankle's still swollen.
You know, broken toes are pretty painful.
6 years ago.
I broke my big toe one time. I was in the weight room cleaning up after the athletes had been in there, and I thought I put the 45-pound plate on the tree, and I missed and dropped it right on my big toe.
Huh?
You might have
Cracked my big toe, like literally like split it. You can see it on the X-ray. No, it just
I mean,
split
it's
in
not
half.
as
So
big as
it's
it was.
Yeah.
It's just.
take it easy for a couple of weeks. So yeah. All right, so here's the foot, okay, so we've got, so again, here's that talus joint, okay, so here is your tibia and your fibula, and so your foot can do this. Okay. Here is your calcaneus bone. Here on the back, this is called the calcaneal tuberosity. So you got a couple of muscles here on the back of the calf. They're called the triceps surae, right? So it's three muscles that come together. Primarily, you've got the, we're going to get into this greater detail. We've got the gastrocnemius, the soleus, and then the posterior tibialis muscle. They all kind of fuse together into a tendon called the triceps surae tendon, or more commonly known as the Achilles tendon, right? So ask Aaron Rodgers about it. He'll tell you all about what happens to it. Oh, I know.
That was
Yeah.
awful.
I know, that's mean, right? So, yeah, that's what happens when you play football when you're that age. So why is, where did we get the name Achilles tendon from? And Achilles heel?
From great.
Didn't they dip Achilles and that was his only weak spot?
Right, so Achilles was a demigod. What's a demigod, guys? Half human, half god. So his father was a mortal and his mom was a water nymph, which was one of the lesser gods, right? And when he was born, his mother took him to the Oracle of Delphi, who predicted that he would be a great warrior, but he would die in battle. Being a good mom, she didn't want that to happen, so she took Achilles to the river Styx, which is the river you take to get to the underworld, and held him by his feet and dunked him in the water. And anything dunked in the river Styx is impervious to human weapons. Right? 20 some odd years later, a guy from Troy named Paris stole one of the Greek king's wives, Helen, and then they went to Troy to get her back. A bunch of stuff happened. So Achilles, who saw the movie with Brad Pitt, right? So Achilles kills Hector, which is the prince of Troy, and then the other prince, Paris, remember the story and hypothesized that his feet, the tips of his feet maybe didn't touch the water, so he shot an arrow through there, which killed him, which is why somebody's one weakness is called their Achilles heels, right? So we call that the Achilles tendon, right? But its technical name is the triceps surae tendon. And then we've got the cuneiform bones. So we got the cuboid bone right here, and then we've got the three cuneiform bones. Okay. So here is the cuboid. Here's the navicular, and then here are the three cuneiform bones. They're called cuneiform bones because to early anatomists it reminded them of cuneiform writing. So in Mesopotamia back in the day, right? It's one of the first forms of writing. It was kind of like block shapes, right? It's called cuneiform writing. And then we've got the metatarsals. So first, second, third, fourth, and fifth metatarsal. Anybody here done karate before or taekwondo or anything like that? Right? So like they kick, with a side like that. And so you're kicking with that fifth metatarsal there. And then we also call these phalanges. So big toe, okay, proximal and distal, and then the rest we got proximal, medial, and distal phalanges. Okay. In your foot, you've got two arches, okay? So we've got a longitudinal arch, and then we have a transverse arch. What's the function of an arch in our foot? Why do we want an arch in our foot? Shock absorption. So humans are bipedal, right? So we are on our feet, and we are, the data suggests that we are evolved to run. Right? We were meant to be a running species. We're very good at running, very, very good at it. So some people say have what they feel to be a fallen arch, right? So flat feet. There are two reasons for which people would have flat feet. So number one, you anatomically don't have much curvature or much of an arch. That would be what we call a true fallen arch. Some people have fallen arches because they have weak musculature of the muscles of the foot, and so when you're standing, your feet are flat, that's a false fallen arch. But if you sit down, the arch comes back, that just means you got weak feet. Your feet are flat no matter whether you're standing or sitting, that means you have an anatomical flat foot. Running is probably not a very good thing for you. How do we help treat weak feet?
Orthotics.
So orthotics is one way of doing it. What's orthotics going to do?
It's gonna pretty much realign like the setting of their foot in the shoe.
Sure. Is it going to strengthen the foot? Not a whole lot, right? So how do we strengthen the foot?
Run.
Run. What kind of footwear do we want to wear?
Barefoot feet. Or
Well, you can
wide
go
foot?
barefoot, but right,
Or
what
wide.
happens if you go barefoot? Right? might step on rocks or glass or nails.
More like Coco
Right,
shoes.
so like what I'm wearing, right, so these are what we would call minimalist shoe, right, so I have like what's called a wide shoe box, the toe box, right, so it keeps it kind of wide and open. Who are the best runners, especially long distance guys? So specifically like Ethiopians, Kenyans, right? So they are what we would call, especially, a lot of the younger kids, right? They run in barefoot or they run in minimalist shoe wear, right? So they build really good feet. Number one, they have better mechanics for running, right? So most people in Western countries where we have like really padded kind of shoes, like what she's wearing there, right? How do we run? We run heel toe. Right? That's how you're supposed to walk, but that's not how you're supposed to run. So when you run heel toe, right, it's not a very mechanically efficient way. How should you run? When you took track in high school, right? How are you supposed to land? You're supposed to land
The ball.
on the balls of your feet, right? So that'll propel you forward. You got that big tendon there, right? So it'll stretch that tendon and propel you forward, right? So if you run barefoot or run in minimalist shoes, you're not going to run heel toe for very long because that's really going to hurt. Right? So there's data to show that. Now, you guys might be a little taken, remember for a while there was like these toe shoes and kind of things that was real popular, right? So people wear these toe shoes and they go running and then they end up messing up their feet because, right, they didn't ease into wearing it, right? So if you've been wearing, sneakers with a lot of padding and support, and you go to minimalist shoe wear and just start running like you always have, like out there on the road, you're gonna mess up your feet pretty quickly. So you've got to like ease into that gradually over time. So like these are becoming more popular. So not only minimalist, but with like a wide toe box. So if you go on Amazon and type in like shoes with wide toe box, you can find them. Some of them aren't real fashionable; they look like clown shoes. So a lot of people end up with like bunions and other like messed up feet because we buy shoes that cram your toes into a toe box, especially you ladies, and to wear footwear that's really not good for your feet. So we have a lot of shoe with a lot of foot and feet problems. Go to Ethiopia, Kenya, you can find anybody with feet problems. So, especially ladies, stop wearing heels and really bad. Okay, let's talk about joints real quick and then we will wrap up. Okay? So a joint is the junction or articulation of any two bones, right? So we can move not at all, some, or quite a bit. Okay? So we have immovable, movable, slightly movable, or freely movable. Okay? So fibrous joints would be those immovable joints. So for example, the sutures in your skull, right? So you've got bones in your skull. Temporal, frontal bone, parietal bone, occipital bone. Those bones are firmly held together. They're not supposed to move at all. And then you have like the distal end of your tibia and fibula, right? Not really spent to move at all other than to go like this. And so those would be sutural or fibrous joints. Then we have cartilaginous joints, which move a little bit. So for example, each of your vertebrae, right? So one individual vertebrae doesn't move a lot, but if you combine it over all the vertebrae, right, you got a fair amount of movement. Also, like you have the pubic symphysis of your pelvis, right? So when you walk, your pelvis actually does this a little bit. At least it's supposed to do that, which is good. So that moves a little bit. By the way, what happens when you're in the last trimester of pregnancy, especially towards the end, 8th, 9th month? What starts to happen to the baby's head?
It drops.
Baby's head starts to drop down into the pelvic opening. So once the baby's head goes down in the pelvic opening, right, mom's pelvis can't rise. So when you walk, right, your pelvis is doing this. Okay? You're 9 months pregnant, you got a baby right there inside of your pelvis. Pelvis can't do that. So how do 9 month pregnant ladies walk?
They waddle.
They literally have to waddle. My sister was pregnant with twins, and every time she'd come over, I played a Oompa song from Willy Wonka and the Chocolate Factory. She did not appreciate the humor of it. Also, your sternum, right? So, right, your chest cavity can rise and fall a little bit, right? If you do CPR, right? It's got a fair amount of movement to it. Okay? And then we have synovial joints, which are most of the joints in the body. So, elbow, shoulders, elbows, knees, hips, ankles, wrists, those are synovial joints. Here, let me show you, that's basically what all this is. Okay, so, synovial joints, you're gonna have articular cartilage on the end of the bones. You're gonna have a fibrous capsule, a joint capsule, and the joint capsule will be filled with this synovial fluid, which has got a very similar consistency to like egg whites, okay? So this would be most of the major joints of the body. These joints are avascular. So how do you circulate the fluid so that you can get nutrients into the joint and waste products out of the joint? There's no blood flow. There's fluid in there. Moving the joint around. So if you move the joint around, you're going to move around and circulate the fluid, which means you can get waste products out and nutrients in. This is why if you keep a joint immobile for long periods of time, like you're sitting in an airplane or right, you're on a long car trip, right? After 4, 5, 6 hours, right, driving, like I got to get out of this car and need a stretch, right? So if you don't move the joints, right, bad things start to happen. As we get older, we tend to move less, we tend to be more mobile, right? So we start to get calcification. That leads to things like arthritis, and we end up with decreased mobility as we get older if we don't do something about it. And that's what's going on inside of those synovial joints. Okay. All right, let's go over the synovial joints real quick, and then I'll let you guys know. Okay, so we've got 2 ball and socket joints. We talked about this, right? So we've got the glenohumeral joint and then the femoral acetabular joint. What are the pros and cons of a ball and socket joint? We'll start with the pros. What are the pros of a ball and socket joint?
Greater range of motion.
Greater range of motion. So a ball and socket joint would be what we'd call a triaxial joint. So we can move in sagittal plane, frontal plane, and transverse plane. What's the downside to a ball and socket joint?
If it's fractured, it's very hard to. Like
So
I know
more-
for a hip, like you would.
More freedom means less stability, right? So there's a trade-off, right? So the more mobile a joint, the less stable a joint is, right? So lots of people end up with shoulder issues, a lot of people end up with hip issues, right? More so than like elbow, okay? We've got a condyloid joint between the metacarpals and the phalanges. So that would be your knuckles, okay? So this would be a dual axial, right? So you can go up and down and left and right. Gliding joints. Okay, so this would be your ankles and your wrists, and then also your vertebrae. We got 2 hinge joints. So hinge joints are just uniplanar. So your elbow and knees, right? So they can just go mostly in the sagittal plane. Your knees can do a little bit of rotation, not a whole lot. And we have a pivot joint, so that's what's between the radius and ulna. And then we've got a saddle joint, which is between the trapezium and the proximal metacarpal of our thumb. This allows us to do a movement which is unique to all primates.
Perfect.
What would we call this movement here? Huh? This is opposition. Like all primates, humans have a opposable thumb. This allows us to grip things, right? Which allows us to make tools and then control the environment around us, right? Which is why we're in control and cats aren't, because if they had the ability to crash stuff, they probably stabbed us by now because their bowl was only 2/3 filled. Okay. All right. Let's take a break right here. And